I'll talk about this in my previous lecture on course classification. In this talk, I will now focus on diagnostic criteria, which are actually one of the most important points we need to see. Today, I'm going to talk about history, diagnostic criteria, and then I'm going to have time to be able to talk. What is the historical evolution of diagnostic criteria? I think that in 1965, when Konk-Maher introduced the concept of space-time propagation, this concept is now being modified to decreased in some forms, such as clinical disease spread over time and space. Possession then first introduced the use of additional clinical or laboratory evidence, which was not available at the time to prove. Spatial and temporal diffusion, so magnetic resonance is evidence of spatial and temporal diffusion, and then in these editions, in 2005 and 2010, magnetic resonance was used to prove this spatial diffusion. And we saw that they were very important points, and the first thing we have to remember is these brainstem and spine. Another really important point is what was given in the 2017 edition of McDonald's criteria. This is where the integration of history and imagery and temporal dissemination must see how everything falls within the scope of possible diseases. Laboratory evidence in terms of diagnostics and neurologist experience, as well as these criteria, must be interpreted in order to be able to try to advocate. These points and exceptions must be considered on a case-by-case basis. In this review and the 2017 diagnostic criteria, McDonald said there were some very important changes. The first is a very important difference because for the first time, the concept of the temporal spread of these new lesions in space in the second moment to consolidate the diagnosis of multiple sclerosis is like a fragmentation because there is evidence that a new point may be replaced by the presence of immunoglobulins in the disease. So the idea here, if you have evidence of immunoglobulins in a continuous process, in a way it can't be done at these points, so this also has to be discussed a lot, but in many cases, the second is, for example, both for evidence of spatial propagation. Both lesions due to MRI attacks, whether asymptomatic or asymptomatic, can be used, and finally the vision of cortical to juxtapocortical lesions. Therefore, after the new version of the standard in 2017, some publications were published. This study, for example, shows the importance of this study because it examines the possibility of damage. This is at the time of the attack. But many of the studies used to validate the criteria looked at evolution after the first attack, some even at the age of 4 or 5. Here are the differences. With regard to the question of how many patients with this new criterion can be diagnosed immediately according to these new versions of the diagnostic criterion, the change is related to a very strong increase from 17% to 72%. This is particularly true because spinal discrimination replaces evidence of these lesions caused by MRI. Where are we at the moment? Well, at the end of last year, we met in Barcelona, Spain. In order to try to use this diagnostic criterion, the concept continues, the results will be presented and then published, and this is the group of people we see involved in this development of this new criterion under the point of such van. This method is also different from the method we showed in the previous versions in 2010 and 2017 and is made by agreement. Be aware that this criterion is considered approved. Therefore, the analysis is quite intensive and extensive, and it is prepared by a large group of meetings. For example, here you can see the different points discussed. They won't let me decide what's going to happen, but because it's still going on, but I'm going to try to summarize some of the points so that I can provide them. Some comments on this issue clearly consider the importance of being able to revise McDonald's 2017 standards, which is almost unanimous in this case. Some considerations I particularly like because it's almost new compared to 2017. These MOGAD-POMS diseases have been diagnosed in MOGAD patients, but these black holes may also improve the accuracy of the diagnosis of POMS and the presentation of the spine and bone marrow, as you can see in the reports, even with this presentation MOGAD sees. We can do this to exclude MOGAD in a way that is very important, especially for these presentations, and we can see that many of the patients who were previously classified as these acute points need to be treated in a subsequent way. In the vast majority of MOGAD cases, so this is a very important point to be able to highlight them, so we finally think we have to see this introduced by Daniel Contamira and these injuries that may also be seen in pediatric cases. However, this is not relevant enough to allow these criteria. Another very important point is the role of comorbidities and the role of aging, because they must interact with a particular differential diagnosis. With these presentations, which may be quite different from the presentations of the past 30 years, another very important point that has been made is that it is particularly important to try to anticipate the diagnosis now in patients who need to be isolated at these points. Therefore, this is the key to considering the potential overlap of these points with recombination and differential diagnosis. So we're trying to use this kind of negative MRI parameter that Daniel talked about. Another really important point is the dogma that we need to solve over time. This is something that has been challenged in 2017 by replacing temporal diffusion with evidence of anomalous synthesis. But, well, the discussion here was that it was a little deeper, because if we see the result, from the points here, more than 85% of patients were included in these points with a 2-year follow-up, and these patients were found to be satisfied with the evidence of temporal transmission, and most of these studies, they were associated with these benefits, which were about 90% of patients had evidence of this temporal transmission, and even after 2 years, which meant that these patients who entered the study were classified as CIS is at very high risk, and this may be related to the temporal spread that is later confirmed in the vast majority of cases. Therefore, this radiologically isolated syndrome is a diagnostic criterion, and I can only predict it because these are evidence predictive points that combine these risk factors can emerge by predicting 90% of conversions over 10 years with 4 or more of these negative and proportional points. This approach, which is obviously possible even at these critical points, can be a very important development, so it can move from clinical to biological diagnosis. Is this the next point after acknowledging these? Of course, this point is also very important when we consider the diagnostic criteria used. Everyone, even she, is very clear about not risking this diagnosis, and another really fundamental point is to discuss these rules and not tell us whether it's strange that the optic nerve must have. This presentation that wasn't included in these diagnostic criteria before is one of the sites where the problem is that when we discussed in 2017 the possibility, which was a very, very long discussion, it was then that she was in charge of proposing the use of the optic nerve. So we can see this spatial diffusion, and we don't disagree that this is a good idea. Therefore, the evidence comes from subclinical neuroticism by MRI, so that this type of involvement can be seen in a common way in this system. For example, here we have new studies of asymptomatic optic nerve involvement, and now we have these different tools to reveal this subclinical optic nerve involvement to take into account this difference. And well, this new MRI and these recovery techniques show us exactly better optic nerve damage. And in the evidence of M4, some of the well done, they have to do with these points in 2009, and we are very clear that in fact it is not even a common point, but it is possible. What do we really need to see these injuries? Point to point. This also shows us that the use of this can increase this sensitivity without compromising. And we see that the exclusion of the use of these points is related to the use of these data to be able to demonstrate. This involvement of the optic nerve can also be revealed by this optical tomography, but we have to have this advantage from this symmetry with these cells and this evaluation. So these data are very interesting. Some studies, as we have shown in the proportion of patients with the time of optic nerve subdentate and first aphasia without optic nerve involvement is not marginal. So optic nerve involvement combined with this has been shown to increase sensitivity without compromise. Specific, and I think it will be a very good decision, and here are some of the studies that support this. Well, I'm going to be very brief here because it's already been discussed and perfectly shown by Dr. Antonetta. I don't need to walk too much. These are the key points, reminding them that enlarged lesions are valuable because they tend to be almost specific to multiple sclerosis. So instead of just counting the injuries and looking at the distribution, here we pay attention to the physical details of the injuries. So this is another way to help reduce the risk of false definitions from EM when multiple sclerosis does not exist. I think this consensus statement is very important to provide a point of view. The central vein sign has been the first of 3 specific or near-specific parameters to characterize lesions as lesions. DM. The sign of the central vein is the first attempt to go in this direction. Of course, there are some features that must be used to evaluate the signs of the central vein, and this type of analysis is now available on most MRI machines, so it's already starting to be used in our clinical practice. And I think it's a very important sign because a lot of studies have shown that this sign, it has a very good type of specificity and sensitivity. Of course, it is important to consider where the threshold is. And of course, the threshold can be an absolute number. Here are the proposed numbers, which are 3 and 6, or it can be a percentage. There are both positive and negative aspects of the election, but in any case, at least the initial assessment here. He led us to use this as a diagnostic criterion to be very specific and pay more attention to specificity, so this is the direction. Wherever everything goes well, number 6 seems to be more appropriate from this point of view. You've heard about this paramagnetic technique that I'm not going to talk about, and I'm not going to talk about injuries either. Let them expand. What better? What's going on in the M era? In recent years, the use of body fluid biomarkers has increased significantly. In the past, we knew it was very unavailable. Oligoclonal bands have long been the only relevant tool, and now we have very interesting tools. Of course, neurofilaments are a very important possible tool, and cerebrospinal fluid light chains are also a very good possibility. This is used in trials where there is a very strong anti-inflammatory reaction. So the reaction is, inside the central nervous system, we would hope to have more of these free light chains for antibody construction. And of course, if we measure these changes in CSF and compare them with the changes in blood by correcting them for the algorithm, we'll see something similar. What we used to do with the index, IGY, a recent study, has documented that this tool has a great advantage in giving numbers. Giving a number is an objective assessment, and we know that for oligoconic bands, it's sometimes not so easy to define the exact number. Recent studies have confirmed the importance and potentially important role of these free, layer-like light chains, and it seems that they are less useful in differential diagnosis. In other neurological diseases, the sensitivity of this band seems to be quite good and very similar, which we might have with the evaluation of oligoconic bands. The good thing is that they don't overlap completely. Some patients may have positive oligoconic bands and free light chains, negative layers, and vice versa. This proportion is small, really small. It can still be helpful in some specific cases, so it is very important to try. Consider this measurement. Well, I'm about to conclude my speech, and these are the proposed revisions, and in a few months you'll hear. What was decided? I could only anticipate them. Will there be a definite moment in the possibility of diagnosis? As I said, I will not go into the second topic I should cover. I only have 4 slides. I think we have already discussed the definition of multiple sclerosis in different ways at this symposium. In particular, try to see if we should rethink the causes. And this was produced by the DM Alliance to question a panel of experts about the opportunity to change the current classification of primary, secondary, progressive, and recurring submissions. On the one hand, it is considered and still possible to have a separation between. And this is also based on the answers to the questionnaire, how can they see? There was some intensity and frequency on the importance of revising the classification. Here you can also see the attitude towards the current clinical course descriptors and some of the key questions we see here. There was a very divided view of what we should continue to use the concepts of active and inactive in course classification, and also the important role of magnetic resonance imaging. From this opposite point of view, it is quite obvious that most people agree to maintain the division between primary and secondary school progression. And the second line is that there is this prevailing view that M is just a course of a disease. So I would like to thank you very much for your attention. And I would like to ask all the rapporteurs in this section to come to the stage in just 5 minutes, because it is very late